In managing respiratory emergencies, our focus is on maintaining a stable airway and ensuring the patient gets enough oxygen to their tissues. The first step is understanding that ventilation and airway control are at the heart of what we do. Without proper ventilation, we run into problems like low oxygen or high carbon dioxide levels, which can cause complications if not addressed. Working in the field means we're often facing challenges like limited tools, tough environments, or even just time pressure. That's where adaptability and quick thinking will come into play. We rely on things like oxygen masks, airway devices, and ventilation techniques to help stabilize our patients. These tools are the backbone of what we do in respiratory care and help us make a real difference. It's important that we become experts in their use and application. Pulmonary management is all about using what's available and knowing how to apply it effectively for each situation. So we'll start with one of our simplest tools. The nasal cannula is one of the most commonly used oxygen delivery devices in pre-hospital and hospital settings. It delivers oxygen at flow rates of 2 to 6 liters per minute, providing an FiO2 ranging from 24 to 44%. This is perfect for patients with mild hypoxemia who don't need a high oxygen concentration. One of its biggest advantages is comfort. It's lightweight and doesn't obstruct the mouth, so patients can eat and talk while wearing it. This makes it great for stable patients who just need a little extra oxygen support. That said, it has its limitations. If a patient is in severe respiratory distress or needs oxygen levels higher than 44%, a nasal cannula won't cut it. In those cases, we'd escalate to a non-rebreather mask or another high-flow device. Using the nasal cannula is simple but effective for the right patients. It's a go-to for a reason. The non-rebreather mask is a high-flow oxygen delivery device that's widely used in emergency situations when patients need a lot of oxygen quickly. This device delivers up to 90 to 100% FiO2 when set at flow rates between 10 and 15 liters per minute. It's great for addressing severe hypoxemia or respiratory distress, especially in situations like trauma, acute respiratory failure, or even carbon monoxide poisoning. The design is pretty straightforward. It includes a face mask that fits snugly, a reservoir bag that stores oxygen, and one-way valves, and these valves let the patient inhale oxygen from the bag while preventing the rebreathing of exhaled carbon dioxide. That said, there are some limitations. To be effective, the mask needs a tight seal around the face. It also depends on the patient being able to breathe on their own, so it's not the right choice for someone in respiratory failure who can't maintain adequate effort. Regular checking the fit and ensuring the reservoir bag stays partially inflated are the key steps to using the non-rebreather mask effectively. Nebulizers are an excellent tool for delivering medication directly to the lower airways in a form that's easy to inhale. They work by turning liquid medication into an aerosol mist, which the patient inhales through a mouthpiece or mask. This makes them particularly helpful for patients who are struggling to coordinate breathing with inhaler use. A steady flow of oxygen or air at 6 to 8 liters per minute drives the nebulizer, ensuring the medication is effectively aerosolized. Typical medications include bronchodilators like albuterol to relieve bronchospasm, corticosteroids to reduce airway inflammation, and some kinds mucolytics to help clear mucus. We often use nebulizers for patients with acute bronchospasm, wheezing, or severe asthma or COPD exacerbations. A few things to keep in mind. Because nebulizers create a mist, there's a risk of aerosolizing infectious particles, so wearing appropriate PPE is important, especially in close quarters. It's also important to monitor the patient's response. Keep an eye on their respiratory rate, lung sounds, and oxygen saturation to make sure the treatment is working. Nebulizers are a practical and effective option for many respiratory conditions, but they do require proper setup and patient monitoring to get the best results. Continuous positive airway pressure, or CPAP, is a highly effective tool for managing acute respiratory distress in conditions like COPD and CHF. It provides constant, steady pressure to the airways throughout both inhalation and exhalation. This helps maintain airway patency and ensures continuous oxygen exchange. Its mechanism of action is threefold. One, it prevents airway collapse, maintaining open airways and improving ventilation. Two, CPAP increases functional residual capacity, ensuring that the lungs remain partially inflated and ready for the next breath. And lastly, by reducing the work of breathing, CPAP alleviates the physical effort required for each breath, allowing the patient to recover more effectively. This approach improves patient outcomes and reduces the need for invasive interventions. In COPD exacerbations, CPAP therapy addresses the underlying pathophysiology of airway obstruction and alveolar hypoventilation, which result in hypercapnia. CPAP stabilizes lower airway pressures, reducing air trapping and promoting better alveolar ventilation. These effects lead to significant benefits, including an improvement in gas exchange and a decrease in the patient's respiratory rate. Overall, CPAP therapy can reduce the need for invasive mechanical ventilation, which leads to better clinical outcomes and a quicker recovery. In the context of acute pulmonary edema caused by CHF, CPAP therapy directly addresses the underlying cardiac dysfunction. Pulmonary edema results in an increased preload and afterload, both of which strain the heart. CPAP increases intrathoracic pressure, reducing venous return and afterload. This eases the workload on the heart and improves left ventricular function. Patients typically experience rapid relief from dyspnea, improved oxygenation, and a decreased likelihood of requiring intubation or mechanical ventilation, which are associated with higher risk and poorer outcomes. So some key things with our CPAP setup. So this is our standard setup. Now, granted, they may look a little bit different over time depending on what manufacturer we're using, depending on what's available. But more or less, they all work exactly the same. So starting at this end, this is called a disconnector, which is a diameter index safety system. So it's just a standard thread size and count for hooking up to oxygen supplies for medical gas. But the disconnector is going to be made of plastic. Now, keep in mind, when you're hooking this up to the wall unit or something like that, those are going to be metal threads. So be careful that you don't cross thread when you're putting this on the wall. Now, if you're hooking this up to an oxygen source in the ambulance and it's not on one of the portable tanks and you're not using the little adapter piece, then you need to use the disc wall connector that's found in the airway bin. Make sure that there's no other way that you're trying to hook that up. Use that piece to hook this up to the wall. It provides the correct leader flow and make sure that the patient is getting adequate oxygen. Now, this piece right here does allow for some FiO2 adjustment if you have that from the manufacturer. Granted, we don't. Ours only provides 30%. That's it. This little orange piece mixes the supplied oxygen with the ambient air and has a viral and bacterial filter in it. You need to make sure that this does not become occluded during the course of its use. So don't allow this to just lay on the bed and then get covered by the sheet or something like that. The corrugated tubing ideally needs to be stretched completely out all the way, not just part of the way, but completely all the way out. That will keep it so that it doesn't get any kinks or doesn't tug on your patient's face. It does create kind of this characteristic hum as well. If it's not humming, that doesn't necessarily mean that the CPAP isn't working or there isn't enough pressure. It may just mean that the tubing's not completely expanded. At this end, you have a little L connector. Now that L connector has a hookup for a nebulizer device on it. Granted, it's a one-way valve. So if this cap isn't covering it, it will still work, but best practice is to keep this cap on there if you're not using it. To make it actually work, all you do is take your nebulizer, you'll hook that up to a secondary oxygen source, plug it into the bottom, and then between 6 and 8 liters. Now, once you're done, just pop it off, put the cap back on, and you're done. The top here is a PEEP valve, PEEP, positive and expiratory pressure. Granted, we don't have adjustable PEEP settings for this. Maybe in the future we might. This PEEP valve can pop off of there if you're not careful. If it does pop off like that, no big deal. You just plug it right back on, okay? It also has a viral and bacterial filter on there so that exhaled breath doesn't come back out to you as a provider. And then this little adapter hooks up to this mask that's provided in the kit. So this is the nose bridge adapter. Essentially, all this does is allow you to adjust the mask to match the plane of the patient's face, make it more comfortable for them. You also have these little Velcro attachments on here. Now, granted, you have 2 of them. The idea is if the patient's head's too small, you have this one that's a little bit further up on the strap so that you can adjust it and make it comfortable for the patient. Or if you were to inadvertently rip this off during the course of putting it on, you have a backup on there as well. These little plastic pieces are for taking air samples. It's really nothing that we're going to worry about. Just make sure that they keep the little plastic piece covering them. Stretch out the corrugated tubing, ensuring that there are no kinks or bends in the line. Then, you're going to install the disconnector onto the oxygen regulator port. Be careful not to cross the threads. Install the face mask onto the L connector and make sure that it's seated. Also, double check that all the cords are closed and you have the correct PEEP valve. Then go ahead and flip the straps over the front of the mask and apply the mask to the patient's face. You can hold the mask to the patient while you're adjusting the straps and flipping them back over and getting them affixed to the plastic face piece. And finally, you'll want to adjust the straps to make them more comfortable for the patient and to make a good seal with the face mask. The bag valve mask, or BVM, is a go-to tool for manually providing positive pressure ventilation to patients who can't breathe effectively on their own. When connected to supplemental oxygen, it can deliver nearly 100% FiO2, making it extremely effective in emergencies where high oxygen levels are needed. The design includes key components like a one-way valve, which ensures the patient gets fresh air with each breath and prevents exhaled air from contaminating the bag. Most BVMs also have a pressure relief valve, sometimes called a pop-off valve, which limits the airway pressure to avoid lung injury. This feature is especially helpful in pediatric patients, but can be overridden when higher pressures are needed for ventilation. Using a BVM effectively has its challenges. Achieving a tight seal on the mask is critically important, particularly in patients with facial trauma or unique anatomy. Overventilation is another risk. Providers need to avoid squeezing the bag too forcefully or too frequently, as this can lead to complications like barotrauma or gastric insufflation. BVMs are an essential part of prehospital care, but their effectiveness depends on proper technique and ongoing reassessment. Effective use of a bag valve mask relies on a combination of proper technique and patient monitoring. First, ensure proper airway positioning. Use the head tilt chin lift maneuver unless there's a suspected spinal injury, in which case you'd go for the jaw thrust. These techniques keep the airway open by preventing the tongue from blocking it. Creating a good mask seal is critically important, and a two-handed technique usually works best. This method involves one person holding the mask in place while another squeezes the bag. It's especially useful for patients with facial trauma, beards, or unusual anatomy. When ventilating, aim for tidal volumes that produce visible chest rise. Overventilation can lead to complications like gastric insufflation or barotrauma, so go slow and steady. Your ventilation rate should be about 10 to 12 breaths per minute for most adults. It's usually about 1 for every 6 seconds. This pace ensures effective oxygenation without overloading the lungs. Finally, always monitor your patient. Use tools like end-tidal CO2 and SpO2 to confirm you're ventilating effectively. Capnography waveforms and oxygen saturation readings give real-time feedback to guide adjustments. By staying mindful of these steps, we can deliver safe and effective manual ventilation in the field. When you're using a BVM, choosing between the one-handed and two-handed techniques often depends on the situation and available personnel. The one-handed technique is commonly used when there's only one provider available. You form a CE grip with one hand to hold the mask in place and use the other hand to squeeze the bag. While efficient in solo rescues, it has its limitations. Creating a tight mask seal can be challenging, especially if the patient's facial structure is complex or soft tissue is causing difficulty. The two-handed technique offers more control and a better seal, especially in challenging cases. With the EC clamp, you place both thumbs on the top of the mask and curl your other fingers into the jawline to lift it upward. For the thenar eminence grip, instead of using just your thumbs, use the base of your palms, your thenar eminences, to apply downward pressure onto the mask while your fingers focus solely on lifting the jaw. Both grips allow for excellent stability and reduce the risk of leaks, but the thenar eminence grip can offer even more seal integrity. When deciding which technique to use, consider the patient's condition and the resources available. If you're alone, you might start with one hand and adjust as more help arrives. For critical situations where optimal ventilation is needed, switching to two hands as soon as possible is the way to go. Positive end expiratory pressure, or PEEP, is a ventilation strategy used to improve oxygenation by keeping alveoli open at the end of expiration. This is especially useful in patients with conditions like pulmonary edema, ARDS, or alveolar collapse, where the alveoli tend to close due to fluid or surfactant dysfunction. Functionally, PEEP increases alveolar stability, which enhances gas exchange and improves oxygenation. Portable PEEP valves, which can be attached to a BVM or ventilator, allow us to deliver specific pressure levels, usually in the range of 5 to 10 centimeters of water. However, there are some cautions to keep in mind. High levels of PEEP can increase intrathoracic pressure, which may reduce venous return to the heart, leading to hypotension. This is especially risky in patients with hypovolemic shock or right-sided heart failure. When using PEEP in the field, we monitor for signs of improved oxygenation, like increased SpO2 levels, while also watching for any hemodynamic changes that might indicate complications. PEEP is a valuable tool, but it requires careful application and monitoring to ensure it's helping the patient without causing additional issues. Oropharyngeal and nasopharyngeal airways are foundational tools for maintaining an open airway, especially when patients can't do it themselves. The OPA is perfect for unconscious patients who don't have a gag reflex. To size it correctly, measure from the corner of the mouth to the angle of the jaw. Insert it carefully, initially upside down and then rotate it 180 degrees as it reaches the pharynx. Just remember, it's contraindicated in patients with an intact gag reflex since it could cause vomiting or laryngospasm. On the other hand, the NPA works well for patients who are semi-conscious or have an intact gag reflex. Also great for cases like jaw injuries or trismus, where the mouth can't fully open. For sizing, measure from the tip of the nose to the earlobe. Make sure to lubricate it before gently inserting it into the nostril. Combining the two can maximize airflow when a single adjunct isn't enough. For example, in a patient with both tongue obstruction and oral trauma, the OPA keeps the oral airway open while the NPA ensures an additional route for oxygen delivery through the nasal passage. Together, these devices can make a big difference in securing a patient's airway when standard measures aren't enough. Predicting difficulties with bag valve mask ventilation can help us prepare for challenges and improve outcomes. The mnemonic ROMAN is a simple way to remember the most common factors that make BVM ventilation tricky. R stands for restricted airway or radiation fibrosis. Conditions like scarring or anatomical restrictions can make it harder to ventilate effectively. O is for obesity, obstructive sleep apnea, or airway obstruction. Extra soft tissue or narrowed airways can increase resistance and reduce airflow. M reminds us to look for mast seal challenges. Stuff like facial hair, trauma, or abnormal anatomy can make getting a good mast seal difficult. In these cases, using a two-handed grip or a larger mask may help. A is for age, particularly patients 55 years or older, who often have reduced airway elasticity or muscle tone, making ventilation less efficient. N refers to patients with no teeth. Edentulous patients may need their dentures left in or special adjustments to the mask to achieve a better seal. Anticipating these challenges and planning alternatives, like using airway adjuncts or switching to supraglottic devices, can save valuable time in critical situations. The iGel is a second-generation supraglottic airway device designed for quick and easy insertion, making it a valuable tool in both pre-hospital and emergency settings. Its non-inflatable gel cuff creates a natural seal around the laryngeal inlet without requiring inflation. This reduces the risk of overinflation-related complications and simplifies the insertion process. The iGel is indicated as an alternative to endotracheal intubation, especially in cases where intubation is infeasible or as a rescue airway during difficult airway management. Proper sizing is critically important. Sizes 3, 4, and 5 are typically used for adult patients and are chosen based on ideal body weight ranges. This ensures the device fits snugly for effective ventilation. Placement is straightforward. Simply advance the eye gel along the natural curvature of the oropharynx until it's properly seated in the hypopharynx. Confirm placement by checking for bilateral chest rise and using end-tidal CO2 to monitor to ensure proper ventilation. However, the eye gel has its limitations. It may not work effectively in patients with low pulmonary compliance or significant lower airway obstruction, as it's not designed to bypass those issues. In these cases, intubation or surgical airway management might be necessary. This device is an excellent option for many airway emergencies, as long as its limitations are kept in mind.
The iGel is a novel and innovative supraglottic airway management device made of a medical-grade thermoplastic elastomer, which is soft, gel-like, and transparent. It took over 5 years of development to perfect a non-inflatable anatomical seal of the pharyngeal, laryngeal, and perilaryngeal structures that would reduce compression trauma. A supraglottic airway without an inflatable cuff has several potential advantages, including easier insertion, minimal risk of tissue compression, and stability after insertion. iGel is a latex-free single patient use device that has a gastric channel to reduce the risk of aspiration. Key components and their function. The soft, non-inflatable gel-like cuff matches the shape and softness of the laryngeal and perilaryngeal frameworks. It helps to provide easy and rapid insertion and reduces the potential for post-operative trauma. An integral gastric channel is provided to reduce the risk of aspiration and allow for passing of a nasogastric tube. The buccal cavity stabilizer eliminates the potential for rotation and aids insertions. An epiglottic rest helps to prevent the epiglottis from downfolding or obstructing the distal opening of the airway. The 15mm connector extends inside the airway tube far enough to provide an integral bite block. Pre-insertion preparation. iGel is supplied in a sterile pouch enclosed in either a protective cradle or a cage pack. This innovative packaging is color-coded for size and designed to ensure the device is maintained in the correct flexion prior to use. It also acts as a base for lubrication. Select the appropriate size iGel according to patient weight. When selecting size, it should be remembered that the iGel cuff does look smaller than the corresponding size of many traditional supraglottic airways with an inflatable cuff. Ensuring that you conform to local policy for hygiene, open the iGel package and take out the protective cradle or cage pack containing the device. In the final minute of pre-oxygenation, remove the iGel and place a small bolus of a water-based lubricant, such as KY jelly, onto the middle of the smooth surface of the cradle or cage pack in preparation for lubrication. Do not use silicone-based lubricants. Grasp the iGel with the opposite free hand along the integral bite block and lubricate the back, sides and front of the cuff with a thin layer of lubricant. This process may be repeated if lubrication is not adequate. After lubrication has been completed, check that no bolus of lubricant remains in the bowl of the cuff or elsewhere on the device. Avoid touching the cuff of the device with your hands. The chin should be gently pressed down before proceeding to insert. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force on the device during insertion. It is not necessary to insert fingers or thumbs into the patient's mouth during the process of insertion. If there is early resistance during insertion, a jaw thrust or insertion with deep rotation is recommended. When inserted to a definitive resistance, the tip of the eye gel should be located into the upper esophageal opening, and the cuff should be located against the laryngeal framework. The incisors should be resting on the integral bite block. The eye gel has a horizontal line on the integral bite block to indicate the optimal position of the teeth. But the teeth may rest safely anywhere on the integral bite block. The eye gel should then be taped down, maxilla to maxilla. When inserting the eye gel, it should be remembered that partial resistance and then a feeling of give way may sometimes be felt before the endpoint resistance is met. This is due to the passage of the bowl of the eye gel through the forcial pillars. This is quite normal and consistent with correct insertion, but in such cases, insertion needs to continue until definitive resistance is felt. Let's look at some eye gel insertions in real patients. Note the sniffing the morning air position and the gentle press down on the chin. See how there is no need for fingers to be inserted in the mouth. There is never a need to apply excessive force or to repeatedly push down on the device once definitive resistance has been felt.
Ideal body weight is a height-based calculation that helps guide safe ventilation practices by estimating lung size rather than total body weight. This approach minimizes the risk of lung injury, particularly in patients who are obese or very small. The formulas for calculating ideal body weight are straightforward. For men, ideal body weight is 50 kilos plus 2.3 times the number of inches over 60. For women, you start at 45.5, and then it's still 2.3 times the number of inches over 60. While you might not calculate this on the fly in the field, knowing rough height ranges can help estimate quickly. In pre-hospital care, we use these kinds of calculations to not only size the eye gel and other devices, but to also help us guide tidal volume settings on ventilators. Understanding and applying ideal body weight ensures safer and more effective ventilatory support in all patient types. Placing an orogastric tube alongside an eye gel is an effective way to decompress the stomach and reduce the risk of gastric insufflation during positive pressure ventilation. Start by choosing the correct OG tube size. For most adults, use a size 12 French tube with eye gel sizes 2 through 5. For smaller patients, like pediatrics, with an eye gel size of less than 2, use a 10 French tube. Measuring the insertion depth is straightforward. Position the tube's tip at the patient's xiphoid process, extend it to the earlobe, and then to the distal end of the eye gel. This gives you an accurate depth for reaching the stomach without overinsertion. Before inserting, apply a water-based lubricant to the distal portion of the tube. Insert it gently through the eye gel's gastric channel, advancing to the measured depth. Avoid force. If you meet resistance, withdraw slightly and readjust. Once inserted, verify placement by connecting the tube to suction and observing for gastric contents, or use auscultation to listen for the sound of air entering the stomach when a small amount is pushed through the tube. Secure the OG tube to the eye gel or the patient's face using adhesive tape to keep it in place during transport or continued care. And make sure you give it regular checks to ensure it remains patent and effective throughout its use. Anticipating challenges with supraglottic airways can save time and improve success rates. The mnemonic RODS helps us quickly identify potential issues. R stands for restricted mouth opening. Most supraglottic devices need at least 3 centimeters of space for insertion, so trismus or jaw trauma can make placement difficult. O highlights obesity or obstructions below the larynx. Excess tissue can interfere with sealing, while obstructions below the supraglottic level may require more advanced airway techniques. D refers to distorted airway anatomy caused by trauma, tumors, or congenital abnormalities. These changes can prevent the device from creating an effective seal, leading to inadequate ventilation. S stands for stiff lungs or low pulmonary compliance, such as in ARDS or severe asthma. These patients need higher ventilation pressures, which can cause leaks or reduce effectiveness with a supraglottic device. For patients where these difficulties are anticipated, it's important to prepare for alternative plans like intubation or surgical airway options. During use, monitor for leaks and ensure ventilation pressures remain within the device's limits. Intubation is the process of inserting an endotracheal tube to secure the airway and facilitate ventilation in critical scenarios. Airway protection is a primary indication, especially in patients with altered mental status, trauma, or neurological impairment. The goal here is to prevent aspiration and ensure airway patency. In respiratory failure, when non-invasive measures like CPAP or BiPAP aren't enough to maintain oxygenation or ventilation, intubation becomes necessary. During cardiac arrest, intubation ensures a patent airway and supports effective ventilation during resuscitative efforts. For conditions causing impending airway compromise, like anaphylaxis, burns, or upper airway obstructions, preemptive intubation prevents complete loss of the airway. Patients requiring prolonged mechanical ventilation, such as those with ARDS or sepsis, often need intubation to manage long-term respiratory support. Trauma-specific indications include facial fractures, neck injuries, and swelling, where securing the airway early prevents obstruction due to structural compromise or edema. Intubation is a systematic process that requires careful execution to ensure patient safety and success. First, we'll look over the procedure broadly to get a sense of what needs to be accomplished, and then we'll review each step in detail. Preparation is the foundation. Gather all necessary equipment, plan for alternative airway management, pre-oxygenate with 100% oxygen to build the patient's reserves, and then position the patient optimally. During blade insertion, introduce the laryngoscope into the right side of the mouth and sweep the tongue to the left to clear the airway for visualization. Carefully identify key landmarks as you walk the laryngoscope blade down the tongue and use external glottic pressure if visualization is difficult. Place the endotracheal tube through the vocal cords, advancing it until the cuff passes the cords. For adults, ensure the tube depth is approximately 20 to 24 centimeters at the teeth. Once the tube is placed, inflate the cuff to create an airtight seal and remove the laryngoscope only after the cuff is fully inflated. Confirm placement with continuous waveform capnography, auscultation of bilateral breath sounds, observation of symmetric chest rise, and check for the absence of gastric sounds. Finally, secure the tube using tape or a commercial tube holder and document the tube size, depth, and securing method. Each step is critical to ensuring a successful and safe intubation, minimizing risk like misplacement or hypoxia. Let's start with the equipment. Intubation requires thorough preparation, starting with the right tools for visualization and airway management. For visualization, have a laryngoscope with appropriately sized blades. The Macintosh blade, with its curved design, is used to lift the epiglottis indirectly via the vallecula. The Miller blade, which is straight, directly lifts the epiglottis. Video laryngoscopes, like the GlideScope or CMAC, are excellent for improving first-pass success, especially in difficult airways. Your airway tools should include a variety of endotracheal tube sizes to match the patient's age and anatomy. A stylet helps shape the endotracheal tube, typically into a hockey stick curve, to aid in insertion. For challenging airways, a bougie acts as an introducer when vocal cords are only partially visible. Oxygenation tools like a bag valve mask connected to an oxygen source ensure the patient remains ventilated before and during intubation. A suction device, such as a Yankauer, is critical for clearing secretions and maintaining a clear view. For monitoring, use waveform capnography to confirm the tube is in the trachea and not the esophagus. A stethoscope helps verify bilateral breath sounds. Finally, secure the tube with tape or a commercial tube holder to prevent displacement during transport or patient movement. Having this equipment ready and within reach reduces delays and improves success during intubation. The laryngoscope is designed to provide a clear view of the vocal cords and glottic structures. Starting with the handle, it serves as the power source for the light and provides an ergonomic grip for stability during laryngoscopy. This is especially important when dealing with challenging airways. The blade attaches to the handle and is available in two main types. The Macintosh blade, which is curved, is designed to indirectly lift the epiglottis by positioning its tip in the vallecula and engaging the hyoepiglottic ligament. The Miller blade, which is straight, directly lifts the epiglottis for a more direct view of the glottic opening. This blade is often preferred for pediatric patients or at anatomically difficult airways. A light source is located at the distal tip of the blade, illuminating the airway to enhance visibility during intubation. Proper blade selection is crucial for success. For adults, sizes 3 or 4 are typically used depending on the patient's anatomy. For pediatric patients, sizes range from 0 to 2, guided by either age or size. A handy formula for estimating pediatric blade size is the blade size is equal to age divided by 4 plus 1. Alternatively, tools like the Breslau tape can provide accurate recommendations. To confirm proper sizing, align the blade alongside the patient's face. The tip should extend from the corner of the mouth to the earlobe. This helps avoid overextension or underreach during laryngoscopy. Video laryngoscopy has transformed airway management by offering an advanced view of the airway, improving both success rates and safety. The key advantage of video laryngoscopy is its enhanced visualization. The camera embedded in the blade provides a magnified and illuminated view of the glottic structures, which is particularly helpful for identifying landmarks that might be missed with direct laryngoscopy. This improved view significantly increases the likelihood of first-pass success, even in challenging airways. Applications include patients with limited neck mobility, such as those with cervical spine injuries or conditions like ankylosing spondylitis, and individuals with obesity or anatomical anomalies that obscure direct visualization. Video laryngoscopes are also valuable tools for training and feedback, allowing instructors to see exactly what the learner is viewing in real time and guide them more effectively. Common devices include the GlideScope and CMAC, both of which are widely used in pre-hospital and hospital settings. These devices have been shown to improve outcomes by enhancing visualization and reducing intubation attempts. Although video laryngoscopy offers many advantages, it still requires practice and familiarity to maximize its potential, especially in high-pressure scenarios. The endotracheal tube is the cornerstone of airway management, designed to secure the airway and facilitate ventilation. Standard endotracheal tubes are the most commonly used and include a cuff at the distal end to create an airtight seal within the trachea. This seal prevents aspiration and allows positive pressure ventilation. For adults, typical sizes range from 7 to 8 millimeters. In pediatric patients, sizing is based on age using the formula age divided by 4 plus 4 for uncuffed tubes or plus 3.5 for a cuffed tube. Specialty endotracheal tubes are tailored for unique situations, although we don't commonly encounter these in pre-hospital medicine. You have reinforced tubes, which are reinforced with a wire coil, making them resistant to kinking. These are ideal for cases where neck positioning may change, such as during surgery. You also have laser-resistant tubes, which are designed for use in laser surgeries that reduce the risk of fire in the airway. There are several adjuncts that enhance intubation success with the endotracheal tube. A stylet is a malleable wire inserted in an endotracheal tube to provide rigidity and shape. Shaping the tube into a gentle hockey stick curve helps guide it through the vocal cords. A bougie is a flexible introducer used in difficult intubations when only a partial view of the vocal cords is available. The bougie is inserted first, and the endotracheal tube is then railroaded over it into position, although there are several other techniques that involve preloading the endotracheal tube onto the bougie. These tools and variations allowed for tailored airway management, improving success in both routine and challenging scenarios. The Mallampati classification is a useful tool for predicting the difficulty of intubation by evaluating the visibility of oropharyngeal structures. The purpose of the classification is to estimate how easily the airway can be visualized and identify patients who might require adjuncts or alternative techniques during intubation. It's divided into 4 classes. Class 1, the soft palate, uvula, and tonsillar pillars are fully visible, suggesting a straightforward intubation. Class 2, only partial visibility of the uvula and soft palate is present, which might indicate mild difficulty. Class 3, only the base of the uvula is visible, signaling potential challenges. In Class 4, the soft palate is not visible at all, which often indicates a high likelihood of a difficult airway. The Mallampati score is particularly valuable for guiding preparation. For instance, patients in classes 3 or 4 may require video laryngoscopy, a bougie, or alternative airway management strategies to ensure success. This classification, combined with other assessments like the lemon mnemonic, helps anticipate challenges and ensures we're prepared for any airway scenario. Successful intubation begins with recognizing and navigating the airway anatomy systematically. Start at the lips, the entry point for the laryngoscope blade. Ensure smooth insertion without trauma, and be cautious around the teeth, avoiding contact that could cause damage. Use the blade to sweep the tongue to the left, clearing the view and creating space for visualization. Walk the blade slowly down the tongue, identifying the anatomy as you go. Identify the uvula as a midline marker to help orient your blade. The soft palate provides additional anatomical guidance, following the natural curvature of the airway. Next, locate the epiglottis, which serves as the gateway to the glottis. The Miller blade directly lifts the epiglottis, while the Macintosh blade indirectly elevates it by placing its tip into the vallecula. After locating the epiglottis, the next step is to count down the structures leading to the glottis. Look for the arytenoid cartilages, which frame the vocal cords and are critical landmarks for identifying the glottic opening. The cuneiform and corniculate cartilages are small protrusions near the arytenoids that provide structural support. Finally, identify the glottic opening, with the vocal cords appearing as pearly white structures. This is your target for tube placement. Use external glottic pressure, applied by an assistant, to adjust the view if necessary. The cricoid cartilage, located just below the glottis, is another important anatomical reference point. The Cormick-Lehane grading system is a widely used method for describing the view of the airway during laryngoscopy. Grade 1 provides a full view of the vocal cords, indicating an ideal scenario for intubation. In Grade 2, only a partial view of the cords or the arytenoids are visible. While this may pose slightly difficult, intubation is still achievable with minor adjustments. Grade 3 offers a visibility of only the epiglottis, suggesting a significant challenge. In these cases, adjuncts like a bougie or a video laryngoscope are often required for success. Grade 4 is the most difficult scenario with no visible vocal cords or epiglottis. Here, alternative techniques like a supraglottic airway or surgical airway may be necessary. Understanding the grade of airway view is important for planning. It also plays an important role in documenting intubation attempts and improving strategies for future cases. Proper confirmation of endotracheal tube placement is a direly critical step in the intubation process to ensure effective ventilation and prevent complications. Start with visual confirmation during the procedure. Observing the tube pass through the vocal cords ensures accurate tracheal placement. Perform auscultation immediately after placement and listen for bilateral breath sounds over the lungs and check for the absence of gastric sounds over the epigastrum. Gastric sounds indicate esophageal intubation and require immediate correction. Use capnography, the gold standard of confirming placement. A continuous waveform and detection of end-tidal CO2 confirms the tube is likely in the trachea. Lack of end-tidal CO2 or a flat waveform suggests misplacement. Observe chest rise during ventilation. Symmetric expansion of the chest is a reliable indicator of proper tube placement. Verify the tube markings at the teeth or gums. For most adults, the endotracheal tube should sit between 20 and 24 centimeters. Additional checks include observing the absence of stomach distension and documenting the tube size, depth, and securing method. Each of these steps ensures the endotracheal tube is functioning as intended, reducing the risk of complications like hypoxia or aspiration. While intubation is a life-saving procedure, it's important to anticipate and recognize potential complications that can arise afterward. Esophageal intubation occurs when the tube is placed in the esophagus instead of the trachea. This can be identified by the absence of a capnography waveform, no breath sounds, and visible gastric distension. You must immediately correct a misplaced tube. Main stem intubation, typically into the right bronchus, happens if the tube is inserted too deeply. It presents with unilateral breath sounds and asymmetric chest rise. The solution is to slightly withdraw the tube while reassessing breath sounds. Laryngospasm involves sudden closure of the airway and is often triggered by irritation during intubation. It can make ventilation difficult and may require positive pressure ventilation or muscle relaxants to resolve. Tracheal trauma can result from overinflating the cuff or forceful intubation. Watch for signs like subcutaneous emphysema or bleeding and take care to minimize pressure during cuff inflation. Aspiration occurs when gastric contents enter the airway, often due to delayed intubation or inadequate suctioning. It's essential to suction thoroughly and act quickly if aspiration occurs. Ventilation-related complications include barotrauma, where excessive airway pressures damage lung tissue, and hypoxia, often caused by improper tube placement or tube obstruction. Recognizing and addressing these issues early is vital for patient safety and successful airway management. The DOPE mnemonic is a quick and systematic approach for troubleshooting problems with intubated patients. D is for displacement. Always start by checking the tube's position. Verify its depth and markings at the teeth or gums. Use capnography and auscultation to confirm tracheal placement. If displacement is suspected, reposition or re-intubate as needed. O is for obstruction. Look for issues such as kinking of the tube, mucus plugs, or foreign objects blocking the airway. Suction the endotracheal tube to clear secretions, and if the obstruction persists, consider replacing the tube. P is for pneumothorax. Suspect this if you notice unilateral breath sounds or increasing difficulty in ventilating. If a tension pneumothorax is suspected, perform needle decompression and prepare for chest tube placement. E is for equipment failure. Always check the functionality of your BVM, ventilator, and oxygen supply. Ensure that all connections are secure and swap out any faulty equipment promptly to restore effective ventilation. The SALAD technique, or suction-assisted laryngoscopy and airway decontamination, is invaluable for managing contaminated airways during intubation. The primary purpose of SALAD is to clear the airway of blood, vomit, or secretions, ensuring a clear field of view and reducing the risk of aspiration. The steps for SALAD include prepare your suction equipment, such as a high-powered suction device with a Yankauer or large-bore catheter, and ensure it's functional and ready. Position the suction catheter near the patient's oropharynx before beginning the procedure for immediate access. During laryngoscopy, advance the suction catheter ahead of the blade to continuously clear debris as it appears. Perform aggressive suctioning to maintain visualization, pausing briefly if needed to manage large amounts of fluid or debris. Keep the suction active throughout the procedure to manage ongoing contamination. Use optimized positioning, such as a slight lateral tilt, to allow gravity to assist in draining fluids away from the glottic structures. The benefits of this technique include reducing aspiration risk and maintaining a clear view of the airway anatomy, which is critical for successful intubation in contaminated airways. This proactive suctioning approach ensures safer and more efficient airway management, even in the most challenging scenarios. Predicting a difficult intubation is important for planning and preparation, ensuring you have the right tools and techniques ready. The lemon mnemonic is a systematic approach to evaluate potential challenges. Look externally for anatomical abnormalities like a receding mandible, large incisors, or trauma to the face or neck that might complicate visualization of the airway. The mouth opening should be at least 3 finger breadths wide for adequate laryngoscope insertion. The mandibular space from the chin to the hyoid bone should also be 3 finger breadths wide. The thyromental distance from the chin to the thyroid cartilage should measure 2 finger breadths for accessible airway alignment. Then, assess the Mallampati score. Patients with a Class 3 or Class 4 view where the uvula and soft palate are minimally visible or not visible at all are more likely to have a difficult airway. Check for obstructions, such as masses, swelling, or foreign bodies, which could block access to the airway. And then finally, evaluate neck mobility. Limited cervical spine movement due to trauma arthritis, or a cervical collar can make aligning the airway axes more challenging. Using the lemon mnemonic helps guide preparation, such as choosing adjuncts like video laryngoscopy, a bougie, or preparing for alternative techniques like a supraglottic or surgical airway. Cricothyrotomy is an emergency airway procedure that involves making an incision through the cricothyroid membrane to access the trachea. It's performed only when other airway techniques, like intubation or supraglottic airway placement, have failed. This procedure is often the last resort option in life-threatening airway emergencies. The indication for cricothyrotomy is that the patient cannot be ventilated and oxygenated by any other means. If you're unable to intubate the patient but can adequately manage their airway with a supraglottic device or simple BVM, there's no need to perform a cricothyrotomy in the field. The final question that needs to be asked and answered prior to performing a cricothyrotomy is, can the patient be oxygenated by any other means? If the answer is no, then initiate the procedure as a life-saving step. Let's go through the cricothyrotomy techniques step by step. Start by gathering all necessary equipment, including a scalpel, alcohol swab, a 6-0 tube, suction, a means of securing the tube, and capnography for confirmation. Position the patient supine and extend the neck unless a cervical spine injury is suspected. Palpate the cricothyroid membrane, the soft depression between the thyroid and cricoid cartilages. Then, cleanse the site with an alcohol swab. For the incision, first, make a vertical incision through the skin over the membrane to expose it. Then, create a horizontal incision through the membrane itself to access the trachea. Insert your finger into the incision to maintain patency and locate the tracheal lumen. This step ensures the bougie is guided accurately. Under the guidance of your finger, advance the bougie into the trachea. The bougie's flexibility allows for smooth navigation even in difficult scenarios. Slide the endotracheal tube over the bougie and advance it into the trachea. Once in place, remove the bougie and inflate the cuff to secure the airway. Verify placement by observing chest rise, auscultating for bilateral breath sounds, and using capnography to detect a continuous end-tidal CO2 waveform. Tape the tube or use a commercial securing device to ensure stability during transport or further management.